Welcome to Pediatric Case Review. Today we'll be discussing acute lymphoblastic leukemia in pediatric patients, the most common childhood malignancy. This lecture provides a comprehensive overview of diagnosis, management, and outcomes for healthcare professionals. A 4-year-old male presents with pallor, fatigue, and bruising. Which of the following statements about acute lymphoblastic leukemia epidemiology is correct? A. Peak incidence is 8 to 10 years. B. More common in females. C. Peak incidence is 2 to 5 years. D. Incidence is decreasing globally. The correct answer is C. Acute lymphoblastic leukemia has a peak incidence between 2 and 5 years of age. It affects 3 to 5 per 100,000 children annually, with a slight male predominance. All represents approximately 25 to 30% of all childhood cancers, making it the most common pediatric malignancy. Which genetic condition is most strongly associated with increased risk of developing pediatric acute lymphoblastic leukemia? A. Neurofibromatosis. B. Down syndrome. C. Turner syndrome. D. Noonan syndrome. The correct answer is B. Children with Down syndrome have a 10 to 20-fold increased risk of developing all compared to the general population. Other conditions associated with increased risk include Li-Fraumeni syndrome, Bloom syndrome, and ataxia-telangiectasia. Specific genetic mutations frequently seen in pediatric ALL include ETV6, RUNX1, TCF3, PBX1, and BCR, ABL1. Which statement best describes the pathophysiology of acute lymphoblastic leukemia? A. Excessive production of mature lymphocytes. B. Malignant transformation of myeloid precursors. C. Clonal proliferation of immature lymphoid progenitors. D. Excessive apoptosis of mature B cells. The correct answer is C. All results from clonal proliferation of immature lymphoid progenitor cells with arrested differentiation at an early stage of development. This leads to rapid accumulation of leukemic blasts in the bone marrow, which impairs normal hematopoiesis. The malignant cells eventually spill into peripheral circulation and can infiltrate other organs. A 3-year-old presents with fever, bruising, and leg pain. What is the most likely mechanism causing the leg pain in pediatric acute lymphoblastic leukemia? A. Vitamin D deficiency. B. Bone marrow infiltration. C. Growing pains. D. Referred pain from splenomegaly. The correct answer is B. Bone and joint pain occurs in 20 to 30% of children with ALL and results from bone marrow infiltration by leukemic cells. This may present as a limp or refusal to walk in young children. Other common presenting symptoms include fever, pallor, bruising, and petechiae, all resulting from bone marrow failure and cytokine release. A 6-year-old with suspected acute lymphoblastic leukemia presents with fever and fatigue. Which physical examination finding is least likely in this patient? A. Lymphadenopathy. B. Hepatosplenomegaly. C. Jaundice. D. Petechiae. The correct answer is C. Jaundice is uncommon in the initial presentation of ALL. The most common physical examination findings include lymphadenopathy in 50 to 60% of patients, hepatosplenomegaly in 60 to 70%, and petechiae or purpura resulting from thrombocytopenia. Pallor from anemia is also frequently observed. A 7-year-old with newly diagnosed acute lymphoblastic leukemia presents with headache and vomiting. What is the most appropriate next step? A. CT head without contrast. B. Lumbar puncture with CSF analysis. C. MRI brain. D. Empiric anticonvulsants. The correct answer is B. Lumbar puncture with cerebrospinal fluid analysis is essential to evaluate for central nervous system involvement, which is present in 5 to 10% of patients at diagnosis. CNS leukemia may cause headache, vomiting, and cranial nerve palsies. CSF cytology showing leukemic blasts is the gold standard for diagnosis of CNS involvement. A child presents with suspected acute lymphoblastic leukemia. Which laboratory finding would be most suggestive of this diagnosis? A. Hemoglobin 8 grams per deciliter. B. Platelet count 75,000 per microliter. C. White blood cell count 3,500 per microliter with absolute neutropenia. D. Peripheral blood with 30% lymphoblasts. The correct answer is D. While anemia, thrombocytopenia, and neutropenia are common in ALL, the presence of lymphoblasts in peripheral blood is most diagnostic. Definitive diagnosis requires bone marrow examination showing 20% or more lymphoblasts. Flow cytometry is essential for immunophenotyping to determine the lineage and subtype, which guides treatment decisions. An 8-year-old is diagnosed with acute lymphoblastic leukemia. Which immunophenotype is most common in pediatric ALL? A. T-cell ALL. B. B-cell ALL. C. Mixed phenotype ALL. D. Natural killer cell ALL. The correct answer is B. B-cell acute lymphoblastic leukemia accounts for 80 to 85% of pediatric ALL cases. T-cell ALL represents 15 to 20% of cases and is more common in older children and adolescents, particularly males. Mixed phenotype acute leukemia is rare, accounting for less than 5% of cases. Which cytogenetic abnormality in pediatric acute lymphoblastic leukemia is associated with a favorable prognosis? A. Philadelphia chromosome, BCR, ABL1. B. MLL rearrangement. C. Hyperdiploidy, more than 50 chromosomes. D. Hypodiploidy, less than 44 chromosomes. The correct answer is C. Hyperdiploidy with more than 50 chromosomes is associated with a favorable prognosis, with survival rates exceeding 90%. Another favorable genetic feature is ETV6, RUNX1 fusion. In contrast, Philadelphia chromosome, BCR, ABL1, MLL gene rearrangements, and hypodiploidy are associated with poorer outcomes and typically require more intensive therapy. A 12-year-old male presents with white blood cell count 75,000 per microliter, B-cell acute lymphoblastic leukemia, and no CNS involvement. How would you classify his risk? A. Standard risk. B. Intermediate risk. C. High risk. D. Very high risk. The correct answer is C. This patient would be classified as high risk based on his age greater than 10 years and initial white blood cell count greater than 50,000 per microliter. Other factors that influence risk stratification include cytogenetic abnormalities, early treatment response, and minimal residual disease. Risk classification is crucial as it guides treatment intensity and duration. What is the goal of induction therapy in pediatric acute lymphoblastic leukemia? A. Complete remission in more than 95% of patients. B. Elimination of minimal residual disease. C. Prevention of CNS disease. D. Long-term maintenance of remission. The correct answer is A. The primary goal of induction therapy is to achieve complete remission in more than 95% of patients. Standard induction regimens include 3 to 4 drugs, vincristine, a corticosteroid, asparaginase, and sometimes an anthracycline. This phase typically lasts 4 to 6 weeks, with response assessment at day 8 and end of induction. Minimal residual disease assessment follows remission. Which statement about central nervous system prophylaxis in pediatric acute lymphoblastic leukemia is correct? A. Cranial radiation is standard for all patients. B. Intrathecal methotrexate is sufficient for most patients. C. CNS prophylaxis is only needed in high-risk patients. D. Systemic chemotherapy does not penetrate the CNS. The correct answer is B. Intrathecal methotrexate is sufficient for most patients without CNS disease at diagnosis. Cranial radiation therapy, once standard, is now reserved for patients with high-risk CNS disease due to long-term neurocognitive side effects. Some protocols use triple intrathecal therapy with methotrexate, cytarabine, and hydrocortisone. Certain systemic drugs like high-dose methotrexate also provide CNS protection. What is the typical duration of therapy for standard-risk pediatric acute lymphoblastic leukemia? A. 6 months. B. 1 year. C. 2 to 2.5 years. D. 3 to 5 years. The correct answer is C. The typical total duration of therapy for standard-risk pediatric ALL is 2 to 2.5 years. Following induction, patients receive consolidation, interim maintenance, delayed intensification, and maintenance phases. High-risk patients may receive more intensive therapy or additional delayed intensification blocks. Historically, boys were treated longer than girls, but this practice varies between protocols. What is the clinical significance of minimal residual disease at the end of induction? A. No prognostic value. B. Strongest predictor of relapse risk. C. Only relevant in T-cell acute lymphoblastic leukemia. D. Only used for research purposes. The correct answer is B. Minimal residual disease status at the end of induction is the strongest predictor of relapse risk in pediatric ALL. MRD is typically measured using flow cytometry or polymerase chain reaction with sensitivity of 1 leukemic cell in 10,000 to 1 million normal cells. Patients with persistent MRD often receive intensified therapy, while those with rapid MRD clearance may be candidates for reduced treatment intensity. Which factor indicates the poorest prognosis in relapsed pediatric acute lymphoblastic leukemia? A. Isolated CNS relapse. B. Early bone marrow relapse. C. Late bone marrow relapse. D. Isolated testicular relapse. The correct answer is B. Early bone marrow relapse, occurring within 18 months of diagnosis, carries the poorest prognosis. Treatment of relapsed ALL typically includes reinduction chemotherapy, often with novel agents like blinatumomab, inotuzumab, or CAR T-cell therapy. Hematopoietic stem cell transplantation is frequently recommended for patients with early bone marrow relapse, while those with isolated extramedullary or late relapse may be cured with chemotherapy alone. A 16-year-old girl treated for acute lymphoblastic leukemia at age 4 presents for follow-up. Which late effect is she most at risk for? A. Secondary acute myeloid leukemia. B. Cardiotoxicity. C. Growth hormone deficiency. D. Osteonecrosis. The correct answer is B. Cardiotoxicity from anthracyclines is a significant concern for long-term survivors, particularly for patients treated at a young age. Other important late effects include neurocognitive deficits, especially with cranial radiation, endocrine disorders, osteonecrosis, more common in adolescents, and secondary malignancies. All survivors require lifelong monitoring in specialized survivorship clinics to address these potential complications. Which immunotherapy has shown remarkable efficacy in relapsed or refractory B-cell acute lymphoblastic leukemia? A. Rituximab. B. CAR T-cell therapy. C. Checkpoint inhibitors. D. Natural killer cell therapy. The correct answer is B. Chimeric antigen receptor T-cell therapy targeting CD19 has shown remarkable efficacy in relapsed or refractory B-cell ALL, with complete remission rates of 80 to 90%. Tisagenlecleucel was the first approved CAR T-cell therapy for pediatric ALL. Other novel agents include the bispecific antibody blinatumomab and the antibody drug conjugate inotuzumab ozogamicin. These immunotherapies are transforming the treatment landscape for high-risk disease. In conclusion, pediatric acute lymphoblastic leukemia has become a remarkable success story with overall survival exceeding 90% in modern protocols. Risk-adapted therapy allows us to minimize toxicity while maintaining efficacy. Emerging immunotherapies and targeted agents continue to improve outcomes for high-risk and relapsed disease. Thank you for watching this pediatric case review presentation. Please follow our channel for more informative content and share your questions in the comments section below.